Thank you.
Thank you for the very kind introduction, Matt. Good afternoon, everyone. I'm Dr. Fu Lian, and today I'll be presenting the topic on the axial length progression with my sight. I have no direct financial or proprietary interests in any companies, products, or services mentioned in this presentation. The content and format of the course is presented without any commercial bias. So first, I'll be going through myopia management. So myopia is estimated that to affect 50% of the world's population by the year 2050, which is about 4.7 billion. And 10% of them will be having high myopia, which is defined as worse than or equals to 5 diopters by the World Health Organization. And why is myopia so particularly concerning? This is due to the potentially blinding related complications associated with myopia. And these complications include retinal detachment, myopic macular degeneration, myopic choroidal neovascularization, as well as glaucoma. These conditions can lead to significant healthcare burden, as well as loss of quality of life and productivity. Axial length itself has been validated in both animals as well as clinical studies with direct relationship between axial length as well as myopia progression. It can be measured by either optical or ultrasound A scan. For optical measurement, it is the distance from the anterior corneal surface to the retinal pigment epithelium, also known as the RPE. Whereas for ultrasound measurement, it is the distance from the anterior corneal surface to the internal limiting membrane. Optical axial length measurement in general is preferred in myopia, particularly for use in children compared to ultrasound measurement. This is due to rapid axial length acquisition in optical measurement, less discomfort to our patients, and it also avoids inaccuracy due to compression in implantation. And these are some companies and devices that utilizes optical axial length measurements. In terms of myopia management, myopia control is divided into 3 broad categories. So first, we have environmental myopia control, which comprise of decreased near work as well as outdoor exposure of at least 2 hours a day. For pharmacological management of myopia, we have anti-muscarinic agent, which comprise of atropine eye drops of varying concentration and doses. Finally, for the third category, we have optical myopia control, which can be divided into spectacle lenses, such as defocus lenses, or contact lenses, which is further divided into auto-K, or defocus soft contact lenses, such as MySight, which we will be presenting today. There's this clinical dilemma and clinical decision as to who do we treat, and when, for what duration, as well as what treatment modality do we use in myopia control. And this is due to the challenges that we face clinically. Firstly, there is difficulty in long-term efficacy assessment. We have difficulty in conducting extended duration of prospective randomized control trial on myopia control efficacy. Secondly, there's ethical and regulatory approval considerations that we need to think about. This includes placebo, which is control group, beyond the proof of efficacy in medical research. Also, parental consent to the use of placebo. And finally, compliance, particularly in older children and in extended duration of follow-up period. So next we'll be talking about MySight and its effect on axial length. What is MySight? Let's give an overview. So MySight is a dual focus optic design and it's a daily disposable contact lens that have been proven effective in slowing down the rate of myopia progression in children 8 to 12 years old, and it has FDA approval since 2019. And in MySight 3 years randomized control trial, it has been shown to have efficacy of 59% in spherical equivalent progression retardation, as well as 52% efficacy in terms of axial length progression. What is the trial of MySight like? We have two arms of this study. First, we have the T6 arms, which comprise of 3 years of MySight treatment, followed by another 3 years of MySight treatment. And hence, T6 implies total 6 years of MySight treatment. And how about the other arm? So first, we have the control group for 3 years, which utilizes the ProClear one-day contact lens. That's a single vision contact lens for 3 years, followed by a switch to MySight contact lens for another 3 years. And hence, we term this second group T3. As we all know, myopia management is like running a marathon. And hence, we would like to answer the 3 questions as depicted here. Firstly, what is the efficacy of MySight in 6 years? We do not want to know 3 years only. We want to know what is the extended duration. How about 6 years? Second question we want to answer is it effective in older children? And the third question we want to know is, what is the cumulative treatment effect of extended MySight use? And hence, the following slides will answer these 3 questions. So first, we create a virtual control group. Using mathematical eye growth model that was calculated using the age and ethnicity of the T3 group. As we recall, T3 comprised of 3 years of control. And this virtual control group will be compared against, firstly, the T6 group that has 6 years of full MySight treatment, and secondly, compared against the T3 group that only have MySight treatment in the second half of the 6 years. So how do we know whether this control group is accurate? We compared the results of this modeled control group, which is known as the estimated annual elongation on the left-hand column, against the measured annual elongation. Recall that we have 3 years of control results in terms of axial length progression. And this comparison showed good agreement between the measured control group, as with T3 part 1, against our model. And hence, we can safely use this modeled control group with our 2 comparisons later on in our study. First, to answer MySight efficacy in 6 years, we compared the estimated axial elongation with our model against the measured axial length elongation in the T6 group throughout the 6 years of study. And what it shows that there is significant reduction in progression of 0.53 mm. So in the control group for entirely 6 years without treatment, the projected estimated axial length elongation is slightly more than 1 millimeter. Whereas for 6 full years of MySight use, the axial elongation was reduced to 0.465 millimeters. And hence, there is an efficacy or treatment effect of 0.53 millimeters. To express it in terms of percentage, I have done the calculation as below. We use 0.53 divided by 1.015, which is the control group, which is 52% in terms of efficacy. So this answers the first question, 52% efficacy for 6 full years of MySight use. So let's move on to answer the second question. Is MySight efficacy in older children? So we compared our model control group for year 4 to 6 against the T3 groups, which has treatment in the last 3 years of their 6-year study. Recall that the T3 group have 3 years of control treatment and was switched to MySight in the last 3 years. And similarly, we do see that there is a 0.266 reduction in progression. So on the left-hand column, we see the estimated axial elongation in the control group, which is about 0.396. And for the measured control group in the T3 for MiSight use for the last 3 years is 0.19. And this works up to the percentage of another 52% reduction in myopia progression, even if you start later on in older children and for 3 years. In order to answer the third question, what is the cumulative effects of MiSight from 8 to 18 years old? As recalled earlier, we have the two arms, T6 and T3 arms, and we have each analyzed axial growth rate in both the control group as well as in the treatment group. Why so? Because as you recall, we recruited 8 to 12 years old in both the control as well as in the treatment arm. So at every year, we have varying ages of children on varying treatment. And hence, this allows us to calculate the analyzed growth rate in both with and without treatment. And with that data, what we do is we perform an estimation of analyzed elongation model. And this answers our third question. So as you can see, the orange line versus the purple line, with and without treatment, there's a significant difference from 8 to 18 years old of 0.87 mm between these two groups. To depict this further, let's look at the table itself. So this is the cumulative treatment effect of MiSight from 8 to 18 years old. First row shows the control arm that is entirely without treatment from 8 to 18 years old. At each year, we can see that the axial elongation ranges from 0.07 mm all the way to 0.30 mm. And for the treatment arm, it ranges lower, 0.04 millimeters up to 0.16 millimeters. And the treatment effect is the difference between these two figures at every year. And measured in terms of percentage, the treatment effect ranges from 46 to 49% in children from 8 to 18 years old, with a cumulative treatment effect of 0.87 mm. So I'd like to conclude this first segment of talk with the following points. First, treatment with MiSight substantially retards myopia eye growth and allowing axial elongation in slowing down axial elongation throughout the 6 years of wear by 52%. It is efficacious in 6 years of MiSight use. Secondly, it is effective in older children as well, even when they were on ProClear for the first 3 years, followed by another 3 years of MiSight use, with an efficacy of 52%. And thirdly, full-time MiSight wear from 8 to up to 18 years old will result in an average myopia control treatment effect of 0.87 millimeters. And finally, I'd like to offer two pearls. Early intervention of myopia control provides the opportunity of accumulating treatment effect over more years, and this can result in a greater total benefit for the child. And secondly, combination therapy can be considered in suboptimal monotherapy treatment. Thank you.
Thanks so much, Lian. We're going to turn this now into a panel discussion, but as we're doing that, delegates here are welcome to have a lunch that you can bring to your seat. We have lunch over here in the corner, and just outside is vegetarian if you prefer that. But if you'd like to grab your lunch quickly, and then we'll be right back with our panel in just a moment. Testing. Okay, I think we're pretty much situated here. Again, you're welcome to grab your lunch as we're talking, but just to continue here for a moment, I'd like to actually start out with myopia assessment. What parameters would you guys say are best for myopia assessment? And Hui, could we start with you?
Thank you for your question. So, especially for now, so there are two main parameters for measurement. Measure the efficacy of the treatment for myopia control. These are the spherical equivalent and the axial length measurement. But until now, because due to the repeatability and because that's for the more precise and now because that the optical biometry works so much better than before, and because it's non-invasive, so now the clinician tend to move and tend to base on the axial elongation more than the spherical equivalent. But for sure, we still use a lot of the measurement on the spherical equivalent to discuss with the patient and parents.
That's great. And I suppose before we continue, Hui, do you have a couple slides that you would like to present here?
Can we go to the slide 5?
Okay, so we're going back to understanding axial length.
Yeah. Okay, can we move a little bit back? One slide back. Okay. Okay. So there's a recent evidence from the publication of Brennan et al. So because they can see, we can see that the variation of the measurement, they compare between the subjective refraction and the non-cycloplegic autorefraction, the cycloplegic refraction, and the axial length measurement. And we can see that the axial length measurement has the least variation between the measurement. So that's why now, so axial length measurement with the optical biometry is much more accurate than the refractive error measurement. So that's why the clinician tend to base on the axial length measurement rather than the spherical equivalent before.
Excellent. So, okay, we're going back to axial length, and you know, just a general question for both of you, which is, if you could just describe it for our audience here again. We have a young group of optometrists. Ophthalmology is also here, but how is myopia progression measured, Lian?
So myopia progression is measured in terms of spherical equivalent as well as axial length progression. I will also advise you to look at the patient holistically to look for parental myopia as well and whether they have high myopia, and this increase their risk of myopia progression. Okay.
Now, what role does axial length really play in myopia progression, Hui?
So because I can move up a little bit over here. Because now the axial length played a really important role in measure and also in the monitoring of the myopia and myopia progression. And other than that, because that all the optical biometry machine now, because they measure not only the axial length, they also measure the corneal curvature, and they also measure the lens thickness. And because until now, there's going some papers published by the Australian team soon. They also based on the ALCR, but because the fraction of the axial length over the corneal curvature, because that also predict the progression and also the definition for the myopia onset.
Now, kids are an important point in all of this, so why would you say, Lilian, it's important to monitor axial length, especially in children?
I agree that axial length is very important, especially in younger children, because during times where you do not perform cycloplegic refraction, their accommodative ability is actually very strong, up to they actually can change significantly the subjective refraction if without cycloplegic eye drops. And hence, axial length measurement provide an objective measurement of myopia progression.
Yeah.
And how often should axial length be measured, and why, Hui?
Yeah, the measurement of axial length, first of all, it has been used for monitoring the myopia progression. So in the protocol, they highly suggest that we need to measure the axial length every 6 months to measure to monitor the progression.
Lilian, how do changes in axial length help predict outcomes over time?
So changes in axial length is something that we monitor and we place great emphasis. This is because the longer the axial length, it is something that is irreversible, and longer axial length predicts future high myopia related complications that can be potentially blinding. As mentioned earlier in my slides, and these high myopia related complications such as myopic macular degeneration currently have no treatment at this point in time, other than if it develop choroidal neovascularization. Then we can treat with antivascular endothelial growth factor injection. But other forms of degeneration, unfortunately, there's no treatment to stop the blinding complications.
Hui, can you meanwhile describe the relationship between axial length and refractive error?
Yeah, there's so many evidence around the world that prove that there is a high correlation between the axial length, the axial elongation, and the progression of spherical equivalent. But like Lilian just said, so because that we need to really focus and really emphasize on the axial and elongation, because that not only because there's some case that the kids has a really flat cornea, but then in those cases, if we only base on the spherical equivalent, then the axial length is already really high. So for example, because that based on the recent population-based research in Japan, they also recognize and they also suggest that when the axial length measurement is higher than 25.9 millimeters in the male and 25.3 millimeters in the female, there's likely have higher risk of developing myopic maculopathy later in their life.
And by the way, how does monitoring axial length help measure the effective treatment, Lilian?
So in general, currently there's no growth chart, no growth curve to allow us to determine what is the optimum axial length elongation at every age in treatment-wise. And hence we have an estimated ballpark figure. In children less than 9 years old, we would prefer them to elongate less than or equals to 0.3 millimeters of axial length. And in older children, children above 9 years old, the estimated axial elongation that is optimal would be estimated at 0.15 millimeter or less in annual.
This last question regarding axial length is for both of you guys. So first of all, do you explain the role of axial length plays in myopia progression to patients and caregivers? And if so, how do you make it easy for them to understand?
Generally, in my clinic, I use an eye model to explain to the parent the growth of the elongation of the eyeball in general. So with an eye model or a pictorial representation would allow parents and even children to understand the progression of myopia better.
Nice, nice.
Okay, so let me show you this slide. Okay. 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 No. Okay. So basically, so when I trying to talk and discuss to the parents or the caregivers for the kids related to the progression of myopia in their kids, normally, firstly for talking to the patient, I mentally based on the spherical equivalent and the prescription because it's much easier for them to understand that. But then I move up to the axial length because for us monitoring the myopia progression, for clinician, I mentally based on the axial length than the prescription. But then luckily, because that in our centers, we have the system of myopia master. So then we have the template and also the curvature. That's not the optimal one like Lilian just mentioned before, but it still have numbers and data from the Asian children. So I can basically show the curvature curve and how on the curve, how on the normal curve, and to show that to the parents and let them know that if their kids tend to progress faster or slower than the normal one.
That's great, guys. Well, thanks for sharing all that. We're going into our next topic now, which is myopia management best practices and treatment modalities. So first question, Lilian. What are some of the main methods and treatments used to control myopia and prevent progression?
That's a great question. As we all know, we are currently focusing on various myopia treatment control modalities. So first, let's talk about conservative treatment, which comprise of environmental techniques, including more outdoor exposure of more than 2 hours a day, as well as cut down near work, any form of near work. And next, we move on to optical form of myopia control. An optical form can be divided into contact lenses as well as specialized myopia control spectacle lenses. So for contact lenses, we have soft contact lens like MiSight and also auto-K lenses. And for defocus spectacle lenses, we have varying brands in the market. We have like Hoya lenses or even Essilor lenses.
Hui, would you like to share a Vietnam perspective on that?
Yeah, absolutely. Yeah, because we all know that Singapore is like the capital for myopia and myopia control treatment. So it's not like that, the same situation in Vietnam because we have the limited resource of the myopia control treatment. Especially we don't have yet MiSight. We are going to have soon. We don't have the defocus lens. We don't have the defocus spectacle lens like the Lenslet or like the DIMS lens. But for the clinical perspective in Vietnam, I highly recommend the Vietnamese clinician that just go ahead and do some kind of myopia treatment for the children. Like Lilian, we can start doing some conservative treatment like the environmental management, and we can start because now we also have some kind of like an atropine treatment. We have quite a good concentration of atropine, so just start and do that. As soon as you have something available for the kids, it's still better than we do nothing for kids.
Back to Lilian, what is your preferred treatment strategy and/or modality to prevent myopia progression in children?
That's a very tricky question because each of the myopia control treatment modalities has its own pros and cons.
Yeah.
And for precision medicine, we need really to cater to each of the children's needs. I give you an example. In the children who have sports or ballet dancing needs, they would not want to wear glasses, and contact lenses will serve as an excellent modality in helping them control myopia progression. But of course, if monotherapy doesn't work, for example, if just by pure contact lens is suboptimal treatment, we can add on myopia control eye drops like atropine in use in tandem and synergistic approach for myopia control.
Hui, does this differ from the strategy of treating adults?
So until now, there's quite limited resource and limited publication about the adulthood myopia and also the adulthood myopia progression, to my knowledge. But until now, but luckily that we have less progression when the kids reach the adulthood, like the age of 16 to 18. But you can see that now, until now, for adulthood, you can see the presentation of Lian just recently, that my site is also a good example and also a good choice for the kids reaching the age of 16 to 18.
And Lilian, how do you determine if a child's axial length is normal for their age?
In general, it's currently difficult. This is a very, very tricky question because we do not have any nomogram as of present with regards to what is the optimal growth rate. It's just like in terms of height measurements, we do have nomogram, but for axial length, we currently do not. Why this is because of many different factors, like different races or different geographical locations have different axial length kind of growth rate. And hence, we need several amount of data before we can actually plot the actual growth rate for each of the individual of each race as well as age.
Is there anything else that you would like to mention about your personal experience using the MySight lenses?
So at Myopia Center and Singapore National Eye Center, we do use MySight, and I do have very good experience with MySight in terms of patient satisfaction as well as outcome for myopia control.
Which patients would you say are ideal candidates for this treatment?
So the ideal candidates for MySight treatment in general, because it's efficacious in 8 to 12 years old, so I would recommend at least within this age range, 8 to 12 years old, you can start MySight treatment, and up to 18 years old. The earlier you start, the greater the cumulative treatment effects you will achieve.
What makes them child-friendly, by the way?
So it is child-friendly, firstly, because it is a soft, daily disposable contact lens, and hence the children do not need specifically to store the contact lenses in cases and need to clean thoroughly as per one-day use. Secondly, it is very comfortable for children. It is soft lenses compared to hard lenses that can be uncomfortable in some children.
Okay. Just a few more questions on MySight. You know, how do they actually slow the progression of myopia?
Okay, so MySight is a dual focus contact lens. So it has multiple rings and it induces peripheral myopic defocus instead of hyperopic defocus. So if you think of the light rays in general, at the peripherally, the light rays usually lands behind the eyeball. And this is thought to simulate the eyeball in lengthening to grow towards the light rays in order for the light rays to fall onto the retina and hence resulting in clear vision. And what we are inducing here is myopic defocus. So we induce the light rays to fall in front of the retina instead of behind the retina and stop the simulation for axial elongation.
What would you say is the myopia control efficacy of MySight?
So myopia control efficacy for MySight for 3 years as well as estimated for 6 years is about 52%.
Okay, and how does the dual focus optical design work?
So the dual focus optical design work by inducing peripheral myopic defocus in terms of the light rays. And this helped to slow down the rate of myopia progression, particularly axial length progression.
How does MySight address the correlation of axial length to refractive control?
So in general, there's currently no direct correlation between axial elongation and the spherical equivalent in general, although you can do an estimation.
Yeah.
But in general, it does slow down both spherical equivalent and axial length by 59% and 52% respectively.
Hui, you're welcome to jump in here too, but I just figured that since we're awaiting MySight in Vietnam, any thoughts on any of this so far?
So I just want to just add one thing because they're just a recent meta-analysis. They meta-analyzed and they calculate the correlation between the spherical equivalent and the axial length. And for 1 millimeters, it could go up to for 2 diopters. But so it's just a matter of like estimation. But like Lilian said before, so the normal range and we expect for the progression of the kids is about 0.3 millimeters per year.
What kind of outcomes, by the way, can patients and caregivers expect with MySight, would you say, Lilian?
So in general, the outcome is the slowing down of myopia progression in both axial length as well as spherical equivalent. Secondly, they can have good visual outcome to be less glasses dependence, particularly in the daytime.
It's a fascinating topic. We're starting to wrap up about MySight, but just a few more questions. How do you evaluate the myopia progression of children with MySight?
So to evaluate myopia progression in MySight, we can evaluate based on both axial length progression as well as spherical equivalent. This is in contrast to auto-K lenses that we can mainly measure based on axial length progression.
Any other benefits that we haven't already covered using MySight contact lenses to manage myopia progression, guys?
In general, I think Dr. Hui and I have covered most of the advantages of MySight.
Okay, then how does MySight help with patient compliance?
So in general, number one, MySight provides good vision, good comfort level, and hence good compliance. Secondly, if it shows effect in terms of myopia progression, which it does, in terms of axial length and spherical equivalent, parents would want to continue to use MySight in this case.
So I'm just going to mention that MySight is the only FDA-approved product for myopia control in the United States and has the longest clinical trial for myopia management. So truly exciting developments here. All right, moving on to the next topic. We're talking about the best equipment for myopia assessment. And Hui, just to reiterate, I asked this question a little bit earlier, but we're getting into this entire segment now. So again, could you just refresh what parameters are measured in a myopia assessment and what device you also use for myopia assessments?
So, as I mentioned before, that there are two main parameters for the for monitoring myopia progression. First is a spherical equivalent. We mainly measure with the cycloplegic autorefraction or like the cycloplegic refraction. Second one is the axial length measurement, and any optical biometry now they can be a good candidate for measuring the axial length.
Could you describe the benefits of using an all-in-one device such as the Myopia Master?
Yes, can we go back to the slide, please? Yeah, so there are three things that I think that would be good for advice like the all-in-one, because that, see, they have first of all, for Myopia Master, they have the, sorry, example, so for this case. Okay. Okay, they have the interface that we can put in the information like the age of onset and then the family history of the myopia, and also they also have the information for the outdoor activity time.
Yeah.
And also we already have the curvature curve of the progression, and we also have the interface how we can have a better interaction with the parents and the caregivers. And the second one, so they have the good measurement and the repeatable measurement for the axial length measurement. And the third one, they have a new program they call that the GRASS one. This one is a GRASS because we all know that the refractive components of includes first of all is the cornea, the lens, and the axial length. So they all measure and they provide the interface showing how much of the diopters of each component contribute to the total refraction of the kids. So that's a great interface for us to talking to the parents and the caregivers.
By the way, how does a device make measuring myopia progression more efficient? And opening up this question both to Hui and Lilian.
So for me, first one is a non-invasive, no touch to the kids, so it's really children friendly. The second one, because they have quite good numbers of the interface, I think that the myopia control needs a lot of interaction and needs a lot of discussion to the parents. So the better the interface and the better interface for us to talk to the parents, so we can have a good communication with the parents, so then the treatment would be easier for us and would be easier for the caregivers.
Any thoughts, Lian?
Definitely agree with Dr. Hui with regards to the optimized platform that Oculus and Myopia Master offer. So in general, I feel that for automated plotting of the myopia progression itself allows not only clinicians to make easier clinical decision based on the growth chart, it also allows explanation to parents and even children easier with regards to their current progression.
Now, Myopia Master measurements are not influenced by the eye's accommodation status. Why does this matter, Hui?
Yes, as we all know that the accommodation is always an issue because we would like to have the precise number for following up and for monitoring the myopia progression. And the accommodation can negatively affect that process. So then if some measurement can be can be independent from the accommodation, it's better for us for monitoring the progression of the kids.
That's great. And how does Myopia Master make axial length measurements easier to understand, would you guys say? Go ahead, Lian.
I can go ahead.
Okay, Hui.
Yeah, the first thing for us, the Myopia Master has the interface that we can, and also they have the crow curve. But I have to acknowledge that because that until now, we still have the limited numbers, like the limited resource for the population, because the number on the system is only for the Asian, not because we need more data. And maybe later on we can have a better growth curve. But until now, because that in our clinic, most of the patients come to our clinic, they are the Asian kids. So it would be better for them to have that interface and discuss with the parents.
Could you also briefly walk us through the process of using Myopia Master?
I don't have the video of doing that, but I can quickly go through like this one because it's super quick measurement. It's like okay, let me see. Okay, this is the measurement of this is the Myopia Master. So because it's just on one click, you can easily measure the three things: the refraction, the biometry, and the keratometry. And also we also have the pupil size on that. And then we move to another computer when the Myopia Master program will be plugged in, and then we can jump in and we can put some information related to the family history, the age of onset, and the history of the myopia, and then they can turn out an interface for us, and they plot the number of the kids on the interface, and then we're ready to go for the discussion to the parents and the kids.
How long does the exam take?
I can say less than 2 minutes.
Great. Could you also explain some of the benefits of using this device in children?
I think that the best thing for using this device that is non-invasive, and that is quick, and that is like they have the interface that they can help us to clearly explain and discuss to the parents.
Is there anything else you guys would like to add about using Myopia Master in clinical practice before we move on to the next round?
I think that we cover quite good data and information for Myopia Master.
Okay. There might be a few more questions coming up, but essentially the next section is about the right assessment to choose the right treatment. Okay, and the first question is, what factors and/or measurements do you consider when prescribing myopia treatment? Lilian.
So when dispensing myopia control treatment, there are several factors that you need to consider. And these factors includes, number one, the patient's current refraction. Okay, I'll go into detail later on. Number 2, the rate of progression. And number 3, the lifestyle of each individual patient. Okay, firstly, why is the refraction important? It's because different myopia treatment has different limitations of up to a certain degree and certain astigmatism you can use. For example, auto-K lenses or even defocus spectacle lenses. They have an upper limit of the myopia itself, the degrees in myopia, as well as the astigmatism that it can correct. So if, for example, you are minus 14 diopters with high astigmatism, I don't think most of these optical devices allows excellent vision for myopia control. Then
So-
you will have to, sorry, go ahead, Matt. Then you will have to consider other forms of treatment like atropine eye drops, or even conservatively like lifestyle modifications.
Back to Hui, how does Myopia Master help determine the most appropriate treatment?
I think Myopia Master is not the key things that to decide which treatment we should choose for these kids rather than the other one. But Myopia Master is the key measurement for us to monitor the progression of myopia during the treatment. But I totally agree with Dr. Fu that for myopia, the factors that Dr. Fu just mentioned to you would be the most important factors that we need to consider first. And as soon as we start, it's better for the kids.
So just to clarify, could Myopia Master help when selecting a treatment?
In my opinion, I don't think myopia can help us to choose one treatment rather than the other. But for Myopia Master, we can measure and we can expect the stigmatism. So in case that we have the high stigmatism, like the ortho-K lens, it would be the optimal option for you. But I still believe that Myopia Master is the best for you if you would like to think about that monitoring myopia progression.
Okay, 2 questions left about the Myopia Master. One is, how can using Myopia Master help patients and caregivers understand the importance of following their treatment plan to slow myopia progression?
I think the best thing on myopia is the crow curve that I showed you before. And when we plotting, because that when we measure the kids longitudinally, and we can plotting the data, the longitudinal data on that, and we can easily show and talk to the parents about the progression, the current progression with or without the treatment of the kids, following the general growth curve. And so that is the best thing that they can understand the importance of the treatment.
Could you add anything additional to the following notion that essentially perhaps Myopia Master could help slow myopia progression in children?
Myopia Master is just the machine to monitor the myopia progression. Myopia Master does not slow the progression, but myopia helps the process that we monitor and the treatment to have a better treatment for the kids.
Excellent. I'd like to now open up for questions from the audience if anybody has anything pressing to ask. We're excited to hear from the audience. Are there any questions for Hui or Lilian? Yes, please, sir. And the mic is coming your way.
So thank you very much for a very interesting discussion. And I'm a glaucoma doctor, but I have my private clinic, so I use conservative treatment for myopic children with atropine. So in Vietnamese market now, we have all kind of concentration available, 0.1 and 0.02 or even 0.025. So, of course, we have to consider other risk factors, like you said, to choose which concentration were the best or the most suitable for one specific child first. But I suppose that you should always start with the lowest concentration and follow up the child and maybe decide later on which one or have to switch to higher concentration. Because I know that now many results from the clinical trials just came out that from Hong Kong they said, well, 0.2 may be the most suitable, the best one, or from Singapore maybe 0.1, or maybe from other country 25. So which one and what we recommend a general ophthalmologist like us to start with?
I think that's a very excellent question because that is what we face in our clinical practice every day. What concentration do we start the children on with regards to atropine eye drops? So as we all know, the higher the atropine concentration or the dose that we go, there is increased risk of potential side effects that comes in the form of difficulty reading near and or glaring under stronger lighting condition due to pupillary dilatation. So we need to balance the risk and benefits. Of course, the higher the concentration, the better the efficacy. For example, if you use 1%, you have efficacy of up to 80% in slowing down myopia progression. But what is the drawback? The drawback will be almost close to 100% you will get side effects. And hence, we want to balance these risk-benefit ratios to an optimum level to benefit our patient. And hence, for precision medicine, you need to look at the patient's profile in general. So if the patient is a fast progressor, okay, even if I see them in clinic, this is the very first time without charting any form of documented progression in my clinic, but based on parental history as well as history of refraction that the parent shows in clinic that is a fast progressor, I wouldn't mind even starting off at 0.025 concentration rather than 0.01 concentration.
Hui, any further comment?
Yeah, that's also the question that I always, there's so many colleagues call me and they all ask also the same question. And I totally agree with Dr. Fu that for the patient profile is the most important, and we need to base on that to define which concentration we should start first. As soon as they have more risk factors like the parental myopia and the level of myopia is too high, and even that we have the rate of progression in the past as too fast, and they are fast progressor, we need to start as soon as possible with the high-low concentration. Like the high-low concentration, let's say that 0.025 or 0.05, rather than start at the beginning with 0.01. Okay.
Any other questions from the floor? TJ?
Can I have another question, please?
Do you need
Can I have another question?
Oh, sorry, TJ, just a second.
Sorry.
Yes, active audience.
So another question is about the use of AutoK for myopic control. Because in the north, for example, in Hanoi, the cornea doctor is so scared of using the AutoK because of the terrible complication. Some children have the infection and have to go to Singapore for the chiroplasty, penetrating chiroplasty. So scared. So what about your opinion and also the Singapore opinion about using AutoK and how to have good monitoring, maybe the good cooperation between the parents and doctor, maybe to prevent the complication?
So that's another excellent question as well. AutoK, as with all contact lenses, have risk of infection, but it also have the benefit of slowing down myopia progression, and hence how to optimize and reduce the risk of infective keratitis in such patients. It can be divided into different factors. So clinician factors, patients factors, as well as parental factors. So for patient-wise, we need to conduct patient education. We need to educate them about what are the potential red flag symptoms like eye redness, eye pain, and also in clinic, in SNEC, we teach them the proper cleaning techniques. We want to watch them, their techniques of putting in and removing the contact lenses, the washing of, importance of washing the contact lens cases. And in the events of any symptoms, any red flags, any eye redness, we ask them to stop the contact lens wear, come to clinic or to the emergency immediately. So that is patient's education. And for parental, we also need parental education because some children are unable to put in the lenses themselves. We need to teach the parent the proper hygiene techniques, the hand washing, same for children as well, as to how to properly remove the lenses and to care for the lenses and when do they need to change the lenses. And most importantly, for both patients and parents, compliance is the most important. So they really need to comply to the safety techniques that we teach them. And from the clinician perspective, it is our role to ensure that all is covered, as in every time they come to clinic, we need to perform a thorough eye examination to check for any punctate epithelial erosions, and also to reiterate the safety techniques to both parents as well as children. How about you, Dr. Lee?
I think that Dr. Fu already covers most of the things for the orthogate, but I would like to add one thing. So every single treatment for myopia control, we need to carefully consider about the risk and benefit and clearly discuss that with the parents and the children prior to this for our decision which treatment would be the best for the kids. And the second thing, until now, I think that the best monitoring process for monitoring the myopia progression using orthogate is the axial length rather than the refraction that the Vietnamese clinicians are normally do now. So I highly recommend to measure the axial length at the baseline prior to the treatment of the orthogate and monitor that over the years of using orthogate rather than only using the refraction.
We have time for just one more question. TJ, do you have a mic over there?
First of all, thank you so much for a very informational panel discussion. That was fantastic. You discussed several advantages of MySight. Are there any disadvantages or ways that it can be improved upon to be better and improve compliance?
So currently, one of the drawbacks about MySight is that it can only correct up to a certain level of degrees as well as minimal astigmatism. So in that case, I understand that CooperVision is about to deliver a higher range that can cover even high myopia range for myopia correction. And this kinds of eliminates the drawback with regards to its limitation in terms of myopia correction itself, as well as the astigmatism. I think they are also working on having toric lenses that corrects for astigmatism.
Well, thank you so much for joining Axial Length and Myopia Control, getting to the root of myopia progression. It's been a great time here with Dr. Lian Fu and Dr. Hui Tran. We look forward to having you at our next Cake and Pie Expo 2.0 session coming right up. Until then, be well, and if you haven't already, grab a lunch. Take care, guys. Cheers.